Assalamualaikum and salam sejahtera to all listeners. Assessing vital signs is a standard component of any patient assessment, especially in shock. The vital signs to be obtained are respiration, pulse oximetry, blood pressure, skin, mental status, and urine output. It is extremely important to get the baseline values and trends since the patient's condition, such as improvement, stability, or deterioration, are identified using this data. Some vital signs findings may present as abnormal and indicate a significant patient pathology, whereas other findings that appear to be abnormal are indeed a normal response. We are going to discuss of some of these normal and abnormal findings that may assist you in more accurately interpreting vital sign data obtained from patients. First, we are going to discuss about respiration. When assessing respiration, it is important to determine not only respiratory rate but also tidal volume. It is two adequates, which is rate and tidal volume, that constitute adequate breathing. If either rate or tidal volume is inadequate, then the patient requires immediate intervention with positive pressure ventilation. On average, adult patients breathe between 12 and 20 times per minute. However, recognize that a patient can have a resting respiratory rate of less than 12 or greater than 20 and not be considered to have an abnormal respiratory rate. As an example, if a patient has a resting respiratory rate of 10 per minute and he is talking clearly and normally, and he is alert and oriented to person, place, and time, a respiratory rate of 10 per minute in this patient will clearly not be considered abnormal. On the other hand, elderly patients typically have higher resting respiratory rate due to decreases in tidal volumes. It will be normal for an elderly patient to have a resting respiratory rate of 20 to 22 per minute. Once again, consider the respiratory rate in conjunction with other physical findings to make a clinical judgment of normalcy. Tachypnea, which is a faster than normal respiratory rate, usually indicates cellular hypoxia, acidosis, or conditions that interfere with gas exchange, ventilation, or perfusion, such as pulmonary edema, pneumonia, and pulmonary embolism. You can expect tachypnea as an early sign in the shock patient with poor tissue perfusion. A patient presents with tachypnea and exhibits no signs of distress and has no evidence of any trauma or any other overt clinical reason will be described as having quiet tachypnea. Quiet tachypnea is often a sign of metabolic acidosis. Tachypnea can be a normal response to pain. In this situation, it will be prudent to obtain a pulse oximeter reading and look for any other clinical signs or symptoms of hypoxia. If none are found and the SpO2 is above 95%, while the patient is breathing room air, you can suspect that tachypnea may be related to pain and anxiety and less to a hypoxic state. Bradypnea may be an indication of head injury, stroke, or toxic syndromes involving central nervous system depressants. Bradypnea may also be an ominous sign of respiratory failure or impending respiratory arrest. Secondly, we are going to discuss about pulse. Pulse rate, volume, and character. Pulse rate is simply determined by measuring the number of beats in 1 minute. This is typically translated into a heart rate. However, be cautious when making the assumption that the pulse always directly correlates with the heart rate. In some conditions, the heart contraction is not strong enough to produce a palpable pulse with each beat. Bradycardia is a lower than normal heart rate. Bradycardia may be due to medical or trauma conditions such as cardiac conduction defect, central nervous system depression, drug overdose, Cushing reflex in a heat-injured patient, poisoning, or an ominous sign of severe hypoxia and impending respiratory and cardiac arrest. There are many other causes of bradycardia. Once again, it is important to consider the bradycardia in relation to the whole patient. Extremely fit athletes and individuals may have very low resting heart rates. They will not exhibit any evidence of hypoperfusion or hemodynamic instability as a result of the low resting heart rate. Assess the mental status, skin perfusion, work of breathing, and blood pressure to gauge the patient's stability. Be aware that patients on beta blockers and calcium channel blockers may not respond with tachycardia when expected due to the blockade of the beta receptor sites and calcium ion movement, respectively. An example is a patient who takes atenolol, which is a beta blocker, who is involved in a traumatic incident and hemorrhaging. The patient's skin is pale, cool, and clammy. He is anxious and tachypnic. However, his heart rate remains less than 90 per minute. The heart rate does not match the typical shock presentation. Upon learning that the patient is taking a beta blocker, it is evident that a high heart rate is not to be expected in this case and should not be used as an effective gauge of severity of shock. The volume of the pulse may provide some information about cardiac output. A strong peripheral pulse usually indicates good left ventricular function and filling as well as contractility. A weak and steady pulse is usually an indication of an increased systemic vascular resistance, poor left ventricular filling, and an ineffective left ventricular contractile force. Thus, pulse volume can provide an indication of the effectiveness of cardiac contraction and blood volume. Pulsus alternans, also known as mechanical alternans or pressure alternans, is identified by a variation in pulse strength from contraction to contraction. The amplitude or the strength of the pulse varies from beat to beat, even though the rhythm remains regular. One pulse wave may be strong and the next may be weak, followed by again a strong pulse. The pulse amplitude basically alternates between strong and weak. This is usually an indication of severe left ventricular dysfunction, and it is important to report to the receiving facility. If you notice a change in amplitude while taking a pulse, continue to assess the pulse while watching the respirations. If you notice a decrease in the pulse amplitude, it weakens or becomes absent during inspiration, it may be an indication of pulsus paradoxus. This may be a subtle finding that is hard to detect in the field. However, it is a significant finding that may indicate severe increases in intrathoracic pressure, such as severe acute asthma attacks and obstructive lung disease, or other conditions such as pericardial tamponade, adhesive pericarditis, advanced congestive heart failure, and hypovolemia. Next, we are going to discuss about SpO2. When obtaining pulse oximetry readings, it is important to document the reading based on the FiO2, which is the fraction of inspired oxygen the patient is breathing. A patient breathing room air, which is 21% oxygen, who has a SpO2 reading of 95% will not be of great concern. However, a patient who has been on a non-rebreather at 15 liters per minute for a period of time and has a SpO2 reading of 95% may be of great concern. Removing the non-rebreather mask in this patient will precipitate a hypoxic state. A patient who presents with a SpO2 reading near or at 100% while on room air but is severely hypoxic is the carbon monoxide poison patient. In this situation, The pulse oximeter reading will not match the patient's signs and symptoms of shock or hypoxia. Next, we are going to talk about blood pressure. The normal range of systolic blood pressure is 100 to 140 mm mercury and 60 to 90 mm mercury for diastolic. Systolic blood pressure is a measure of left ventricular function. It is important to note that a diastolic blood pressure represents more than just the relaxed phase of the cardiac cycle. Diastole is a direct measure of the degree of vasoconstriction or vascular resistance. Patient is compensating for an abnormally high blood pressure by vasodilation, so diastolic will be low. Abnormally low blood pressure will lead to vasoconstriction, so diastolic will be high. This may provide an indication of how well a patient is compensating for changes in cardiac output. A pulse pressure is determined by subtracting diastolic blood pressure from systolic blood pressure. A normal pulse pressure is often noted as 30 to 40 mm mercury. More specifically, a narrow pulse pressure is one that is less than 25% of the systolic blood pressure. A narrow pulse pressure may be an indication of a decreasing cardiac output and increasing peripheral vascular resistance associated with systemic vasoconstriction. A wide pulse pressure is greater than 50% of the systolic blood pressure. A wide pulse pressure may be seen in brain-injured patients exhibiting Cushing reflex, where the systolic blood pressure drastically increases to maintain cerebral perfusion, but the diastolic remains normal or low. When assessing a patient complaining of chest pain or mid-scapular pain, measure the blood pressure in both upper arms and compare the systolic readings. If there is a difference of 10 to 20 mm mercury in the systolic blood pressure between both extremities, it may be an indication of an aortic dissection. There is inherent variation of systolic blood pressure and diastolic blood pressure between each reading, so it is better to use mean arterial pressure, which is MAP, to guide resuscitation. Now, we are going to discuss about the skin. We are going to discuss the evaluation of skin, assess the patient's skin color, temperature, and condition. Abnormal skin color may include pallor, cyanosis, flushing or redness, mottling, or jaundice. Cyanosis is a lead sign of hypoxia or poor perfusion states. Redness or flushing is typically a result of peripheral vasodilation. Pallor is an early sign of hypoxia and is also seen in poor perfusion states. Mottling occurs when blood stagnates in an area of poor perfusion and becomes deoxygenated. Jaundice, a yellow coloring of the skin and sclera, is a sign of hepatic failure. Abnormal skin temperatures may be cool, cold, or hot. When assessing the skin, be sure to take into account the ambient temperature. Hot skin temperature may be an indication of a significantly increased body core temperature. Peripheral vasoconstriction will cause the warm red blood in the skin to be shunted to the core of the body, resulting in cool skin temperature. Cold skin usually occurs as a result of a significant decrease in the body's core temperature. Capillary refill is a useful test of peripheral perfusion status, especially in pediatric patients. CRT is abnormal if it is more than 2 seconds. The best place to test for capillary refill in children is on the forearm or over the patella. Next, we're going to discuss a bit on mental status. Mental status will be altered when there is poor perfusion to the brain. The patient may be agitated and combative or obtunded. It is useful as part of the monitoring of our resuscitation, and as well as to determine whether the patient is improving or deteriorating. We also can monitor the urine output. Renal function is an important predictor of the presence of shock. Inadequate renal blood flow results in decreased urine output. Oliguria is one of the earliest signs of inadequate perfusion at the tissue level. Decreases in urine output as a result of hypovolemia are seen before changes in heart rate or blood pressure. Responses of urine output to therapeutic interventions can guide shock resuscitation as long as confounding factors are not present. For example, diabetes insipidus, diabetic ketoacidosis, diuretic therapy, or renal tubular dysfunction. Simply stated, shock is a state of inadequate perfusion. Therefore, cells don't receive an adequate supply of oxygen or removal of waste. 3 stages of shock exist: compensated, uncompensated, and irreversible. Caregivers should act quickly to keep compensated shock from progressing into decompensated shock. All efforts should be undertaken to avoid irreversible shock. Compensated shock occurs early while the body is still able to compensate for a shortfall in one or more of these 3 areas of perfusion: the heart rate, the stroke volume, and/or peripheral vascular resistance. The signs and symptoms of this stage of shock include tachycardia and tachypnea, as well as cool, pale, and diaphoretic skin. The patient's blood pressure may be within normal ranges during compensatory shock. Mental status may also be normal during this early stage. Uncompensated shock occurs when the compensatory mechanism fails and the patient's condition deteriorates. The hallmark sign of uncompensated shock is a reduction in blood pressure. Other signs include decreased mental status, tachycardia, tachypnea, thirst, reduced body temperature, and skin that is cool, sweaty, and pale. If untreated or inadequately treated, the patient may lapse into irreversible shock. As its name implies, this latter category of shock will lead to the patient's demise because it can't be reversed. In conclusion, abnormal findings in the vital signs may provide clear indications of certain conditions. It is important to understand what is considered to be truly normal and abnormal. It is evident that some abnormal findings in one patient age group may be normal in another. Anytime an abnormal vital sign is identified, process it cognitively and consider it in relation to the whole patient assessment. Thank you.